Say, oh, got to go to the bathroom. And Lisa never had to go to the bathroom. I don't have to go to the bathroom. Why don't you have to go to the bathroom? I have 3 kidneys. Wow. Oh, that's why you don't have to. Well, now I think back on that, and I'm thinking 3 kidneys. You should be going more often. But I've seen. So she had 1 kidney that usually they're much smaller. It's like 1 kidney kind of not cut in half, but like 1 kidney is actually big 2. Sometimes you can have 2 kidneys with 1 ureter, 2 kidneys with 2 ureters, and then it comes together. It's all different variations. You probably studied that already in your urinary issues classes. Hirschsprung's disease, so any type of abdomen, bowel, polycystic kidneys, there is an ultrasound of that. Meckel's, diverticulum, all of these intestinal issues, hydronephrosis, those will all be indications for an abdomen exam. Urinary tract infections, these are very common. These are both very common for pediatric patients. So positioning, so for an adult, you do the mid-sagittal plane at the iliac crest, right? For an abdomen, so where are you going to do that for a patient, for a pediatric patient? So we usually do 1 inch above the umbilicus. So that is not, we preach don't use soft tissue landmarks, but in this case, you can use that. So 1 inch above that, and same kind of criteria, no rotation, vertebral column in the middle, and here's the erect abdomen. You can see the pediatric patient in the pigostat, not very happy. In fact, I'm surprised there's the top right there. I was going to say, I'm surprised his arms. There's the top of so you can raise the seat and get them up a little bit higher, or stand them upright if they're able to cooperate. Here somebody's holding the patient's arms out of the way. Looks kind of harsh, huh? Looks like they're pulling a little bit too much. And again, you can do your lateral decubitus, or either with them lateral decubitus or dorsal decubitus. Nothing different there. So skeletal system, there's a lot of stuff for that. All of this is for bone, and looking at all the different types of issues. And these are listed in your textbook, I think, also. This one was a classic question, and I've got it on the slide, and I remember, I think it was on the ART exam, but that, a long time ago. I don't know that it still is, but what is done, what method is done to image clubfoot? And it's the Kite Method, and so I have a slide for that. So sometimes, so again, recognize all these, that these are bony structures as opposed to soft tissue of the abdomen or the chest. So breaking away of the tibial tuberosity on the tibia, Osgood-Schlatter's. So these are just some of the developmental issues. The leg have Earth's disease, the flattening of the femoral head compared to the other one. Can you see that it's kind of not formed properly? Just some of the different pathologies that can be seen. This is juvenile rheumatoid arthritis. So if you're seeing JRA and you don't know what that means, be sure to look it up. Poor development of the bones. Here's the clubfoot. The feet have grown inverted like that, and so just some of the different things that you can see. Look at that. That's terrible. So again, I don't know why this is 2005, so this is an older picture. I'd hate to think that they would do that now. Again, the gloves are going to be more of an issue than seeing the patient. And what happened to their arm? Did they break it and we're doing this? So be very careful with your pediatric patients. Are they crying because you're hurting them again and they hurt their arm? I don't know. And then, so here they're using sandbag for the other leg just to hold it out of the way. They're using some tape to hold the leg still. It looks like the patient's cooperating. When you're having to do all of this, it takes a little bit more time. So with your pediatric patients, don't expect to go in there and rush through it like you maybe would for an adult. So it is going to take a little bit more time. It does help to have a colleague work with you to set things up, that sort of thing, to expedite the exam. But it does take a little bit more time. Here again is the club fit, and this is the Kite Method. What is the Kite Method? I could have made this up. Two projections at 90 degrees to each other. So you know how you do a foot x-ray and you put the plantar surface of the foot onto the image receptor? No. Here you're not going to be able to do that. So you just take one AP and one cross table, or turn the patient onto each side and take the image just however their foot lays, and then turn them on the other side. So that was a question on my ART exam. What type of imaging method is used for congenital clubfoot? And the Kite Method. Now, they're kind of getting away from names. So like a Waters view would not necessarily be called a Waters view. It'd be a what? Parieto-acanthial projection, that sort of thing. So even though we still call it Waters, they may not have that on your test. So make sure you know the Waters for out in clinical. When I say go do a Waters, you know what I'm talking about. And then for your test, you need to know parieto-acanthial because it may not say Waters. So here, just look at those little feet. Oh my God, I just want to eat that. It's so cute. So here, just showing you different ones. Still the same. You know, the imaging is not any different than what you would do for a Townsend adult, right? So same kind of criteria. So you can imagine if you're having, you know, it takes a little practice with an adult skull, you can imagine with a pediatric skull. And it looks like, I don't know if they twisted the tape there or not, it kind of looks like they did, but if they're able to cooperate, it helps. Now look at this, right? An alien, right? Look, the face tends to, this is a AP skull, so the face tends to be a little bit smaller in the skull. Their face hasn't grown into their skull yet, you know, as far as catching up with where's that one kid with see, look how little the face is and look how big the skull is. And they're crying, and they'll also have two sets of teeth typically with that. So skull imaging is a little tricky. Like I said, especially I don't have one of the Waters, but you get the head too far back and that upper row of teeth just go right into the sinuses. So when I do a pediatric patient for a Waters, you know how your patients are like this? Pediatric patients are pretty much just straight on. Maybe their chin's up just slightly. The MML would not work for that. So a little bit different imaging for our pediatric patients. Our upper GIs, our fluoro procedures, our fluoro procedures, those are going to be different, not necessarily in the exam, but in the prep, right? So what's the prep for an adult for a BE? What's the prep for an adult for an upper GI? What is it for an upper GI? That's easy. MPO for 8 hours. You would never do that to a pediatric, a newborn. You would never do that to a 6-month-old. That's too long for them to go without eating. And so, so there's going to be some modification. If you do an IVP on an adult, we use any, you know, those big 50 cc syringes. Sometimes they'll use 2 of them, 100 cc's. You would never use that much on a pediatric patient. So depending, a lot of times it's not the size of the patient that we, or the age of the patient, age or size of the patient that we look at when we're determining how much barium to give them, how much contrast we need to give them for whatever exam. What is it that, you know, that we look at for our pediatric patients when we're determining how much of a contrast that they're going to have? It'll be their weight, absolutely, it'll be their weight. So that is something you would want to take to your radiologist or let them know, or ask the mom or dad or whoever, try to find out about how much they weigh so that that determination can be made for the exam. So, so upper GI prep for an infant to a 1-year-old, it says 4 hours before the exam, so we wouldn't want any milk or whatever in the stomach before that. And so when you're an older, pretty much what we do for our adult patients. The lower GI, so what's the prep for an adult? You have to do the cathartics, NPO past midnight, low residue diet, all that sort of stuff. So for infants to 2-year-olds, we don't do any prep for that. And the 2 to 10 is pretty much what we do for an adult. Maybe the enema used is for a pediatric patient as opposed to an adult. So what are the contraindications to laxatives? You would want to know that if I were to ask you a question. And what is a laxative? The other name is a cathartic. Same thing, right? Did you learn that? Okay. And so these are, as an adult, as with a pediatric patient. So just make sure, this should not be new information to you, but just make sure you, in case I have a test question about that, I know what the contraindications for that prep is. The other thing I want you to note on a BE, looking at the barium, this is probably way too much barium for a BE pediatric patient. But what is different here?
Catheter?
The tubing, right. So instead of using the tube with the balloon.
Use a French, right?
Yeah. And so you would probably just use a regular catheter, not necessarily what we call a Bardex catheter with the balloon on it, or a Foley catheter. So how do you get that to stay in the patient?
Tape it.
Very good. Put those cheeks together, a piece of tape, and that helps. But that's something that you're going to have to watch and maybe have a hand on as you're turning the patient for the doctor and stuff. So we would not use an adult enema tip for a pediatric patient, of course. And then here, back to an upper GI study, how much are they going to drink? So newborn to a year, it says 2 to 4 ounces, and then as it increases, here we're doing it in years, but typically it's more of a weight thing. But it's up to the doctor. The doctor's going to determine how much, you can have it all ready to go, and it'll be up to the doctor as to how much they're going to drink or to swallow. What do we do for our pediatric patients? And this works out great. Have you done a pediatric upper GI? Nobody yet? You have? How did you give them the contrast?
With the sugar water.
Oh, interesting. Tell me.
When we get the bottle, we put
Okay, so that was what I wanted. You did it in a bottle, right? So you put the contrast media not in a cup because they can't drink from a cup, but you put it in a bottle, and then sugar water and barium.
Yeah, we dilute it like 1-to-1 solution.
Excellent, good to know. See, that's something new that I learned just now. Sugar water to dilute it. That's nice. Makes it a little bit sweet. They're going to want it. They're also going to want it because they're hungry. So, so do you, the nipple of the bottle, do you make it bigger with the needle?
Yeah.
Okay, so you get a large bore sterile needle and put it in there to make that opening of the nipple a little bit bigger so that they can drink that thicker barium through it. The barium's diluted from what your adults would use. And so did they have any trouble drinking it?
No, they drank from water when we started giving it to them.
Oh, okay, there you go. That's awesome. So usually it's pretty easy to do with our pediatric patients. We give them the bottle. BCUGs are done quite often. Have you done any of these on a pediatric patient?
Yeah.
Okay, you have anybody else? No? These are, actually children are a little bit easier to do than I would say the adults, just because avoiding cystourethrogram, as you learn, they have to void under fluoroscopy. And so to tell an adult, especially not even an adult female, at this point, a teenage female, teenagers, a young female is hard because, again, it's like, okay, let that contrast media out as we fluoro you, and we're all standing around wanting you to
pee.
Right, and I try not to ever use that word. I don't know what Dr. Friend has. I've done a lot of these, and I never say go to the bathroom, pee, urinate, because that's not something we were taught to do in front of other people on a table. There are places you go for that. And so I would say the contrast media is all in your bladder. You need to let that contrast media out. Really make it very clinical, I guess. but we've had to run water, we've had to act like we weren't really watching, we've kind of talked all kinds of things to get the patient to relax and then to let this contrast media out. But you can see, here's the contrast-filled bladder, and reflux shows the contrast media going back up to the kidney. On a VCUG, only the bladder is filled with contrast. So if the contrast is going back up and you see the kidney and see this, that means uterovesical is not keeping the urine into the bladder. It's coming back up. So that coming back up, urine, this is contrast media, but when urine comes back up, it can cause infections. So you get these urinary tract infections due to the reflux. And that can cause everything to dilate. Look how big the ureters are. So, and that usually happens during fluoroscopy. It happens during the first time instilling the contrast media the first time into the bladder, and then when the bladder's full. So it usually happens at 2 stages, or at least one or the other. And then you can see this bladder is pretty full and going back up. And you can see it shoot back up with fluoro. And so again, here's iodinated contrast media according to weight and to how much. So you don't need to memorize these or anything like that. My point being is that you need to keep in mind that you would not give a pediatric patient the same amount or dose of anything as you would for an adult, whether it's medication or contrast media. It's going to be different. And if it's not your call to make, it's the radiologist's call to make. I went to a Kaiser symposium year before last, a couple years ago, and the keynote speaker was a gentleman who was in a car accident. His child, his wife died, but his child survived and was taken to the hospital and was going to recover, and was given an adult dose of some medication that caused them to die. And so it, just to listen to his whole story was just gut-wrenching. And so the point being, and his point being, was that with your pediatric patients, you just double check, what you're giving them, and to make sure that it is, the correct dose. No one did it on purpose. It was an accident, of course, but that doesn't make it better. This is my favorite slide. Oh, I'd take him too. I would take. He's cute. Oh, that baby is like if there was a catalog and I could just go that one. Oh, that would be it. All mine. So, oh God, and I mean, here this baby's gonna have an IVU. I can't even stand the thought. Look how cute. Okay, I gotta go. It's not over yet. I just want to show you something. Don't get excited yet. But how cute is that little baby? I would just talk to the baby and baby talk, and not even talk to them. Yeah. Where are my slides? Oh, hang on. I just wanted to show you. Oh, that's why. I didn't put these in yours. Just because it'd be too much. Let's see. I can do this. Oh yeah, here they are. Okay, so I was in this hospital in Dallas, and this was a Shriner, or Scottish Rite, Scottish Rite. And this was their sign outside. So this is all a pediatric hospital. So I got a private tour through here, and it was just absolutely incredible. So I just wanted to share some of the pictures. So this was the first thing that caught my eye. So you can imagine as a young child, you're having to go to the hospital, because you've been sick, and to see that, I mean, that is less scary than, you know, a normal hospital sign. So I just thought that was kind of interesting. So as you notice, as you look at these pictures, not of the people, but of the colors, look at the floor, the walls, the elevator. So here in the hallways, they had an aquarium with fish. So things to distract while you're waiting or going by and you see fish. Oh, how nice, how happy, you know. Here's a train set looking at, in a showcase. You can imagine the nurse saying, okay, we got through waiting, now go down, find the airplane room, find the airplane, that's your room, making a little game out of it kind of thing. So you have doors like that. Here's a waiting room. Oh my gosh, this was so cool. I think I have another picture. This was so cool. We spent 30 minutes and they're just going around looking at, they had all sorts of paraphernalia from, you know, the Mavericks and Rangers and whoever, you know, all sorts of cool items in these cases, so you could go around and look to see autographed whatever. And so I thought that was pretty neat. This was out in the atrium, so they couldn't play on it, but this was a pirate ship that they could ooh and ah over and be distracted again while you're waiting, and the kids can go out there and look at it. Here's another waiting room. So again, notice the little chairs and the scenery. So here's another waiting room. So they made this one the space. And this is the hallway down there. So just kind of cool stuff. Here's a restroom, so we had little kids on there. Everything's always little kids. This is in the radiology department. You've probably seen this before. Here's the wall unit, and there's a scoliosis board on there. Pediatric patients who have been diagnosed with scoliosis or any spine deformity will be x-rayed all throughout, you know, their life periodically. So radiation protection is always important with our pediatric patients, as you all know. So here's an exam room. They had some little toys in there, a little chair for the child to sit on rather than sitting them in an adult chair. Here are the elevators looking at the colors. They have a wagon. How fun, pull, you know, the patient in a wagon to the next room or wherever they need to go. You can see the train set or whatever that is in there. So here's their room, 308, and they can put the patient's name. They wrote the patient's name on there. And then always, you know, surveys. They had that there, and they probably have them at your hospital too. When a patient is in the hospital and they've been released, they'll have them do surveys, and they'll mention names, and good and bad. So they'll say Lynn in radiology, blah, 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 fill in the blank, you know. And so just remember that you're always being evaluated, and especially pediatric patients, those parents are watching how you treat their children and what you do for them. More so, they care about that more so than what they would care about themselves. So while they would handle however they're being treated in the hospital, they are not going to tolerate that towards their children. So just always be aware of that. So I just kind of wanted to show you some pictures of a pediatric hospital and what some of the cool things that they can do with that.